Good afternoon. Today is October 11th, 2024. This is United Medical, UnitedTV. My name is Kamal Erkan. Today, we are going to have our 2 p.m. sessions with 2 different topics. Donna Gunkel, one of our directors in clinical integration, and later on, Anthony Anugu, one of our directors in the contracting, they're gonna join me. But first, we want to start with the update from the latest in the United States. This is the Hurricane Milton devastation. Right now, millions of people are actually struggling with the hurricane. So there are so many people who are impacted by this. This is one of the worst, probably in the last several years. Someone who has seen Hurricane Katrina in 2005, I believe. So if this is worse than that, I don't know how bad it's going to be. Hopefully people who are there are getting proper help. Right now, so far, about 17 people lost their lives, and more than 4 million people don't have access to power and other main crucial needs that they have day to day. A lot of tornadoes and flooding are happening. You can see some of those in the video that's running. One of the issues from our healthcare provider standpoint, the mental health concerns and the recovery from those who are actually injured from what's happening with the hurricane is something that we are going to be following very closely. Hopefully, things are going to get better, and this would be the worst part of it. And tomorrow it's going to be a better day. So, it's not like every day we have to, come up or we have to present good news. Unfortunately, this is one of those, but this is part of what we have to go through every day. So what I see, one of the issues that I want to actually point out, last year we had a session with Governor John Carney, and then we did actually address the issue on climate change. And one of the points that we tried to make was, hey, this is not just climate change, but also people who are building in those places that we know they're going to be hit by these types of tornadoes and other types of stuff. So we need to really actually reconsider the way that we are structuring these cities, states, and not to promote more and more people are going there. So when you have so many buildings, the residential, commercial, those buildings, those commercial and residential structures needed to be supported by people who are not at the same level of income, and then they are not able to afford the same type of homes. A lot of people who are actually seeing the damage, they are not really million-dollar homes. They are going to be happening in a lot of poverty neighborhoods. And that's why we were trying to point out that this is something that we need to really stop doing, stop encouraging people to move to these areas. And it is just devastating. And we will be praying for those who are who need help, and then hopefully things are going to be over soon. Now, having said all this, we are going to continue with our clinical presentations, and Donna Gunkel is going to join me. Donna is in the studio first time with me. The only thing, Donna, I think the speaker is on your laptop. I think it's good. All right. On the bottom right, if you can turn the audio totally off. Oh, that's what it is.
I muted that. Can you hear me now?
I think you are on mute now. Okay, so it's good now. All right, so we'll be able to start now. So Donna, you have, of course, you do the clinical presentation with us on the diabetes side, and then a couple of times you join us for non-diabetes topics. Today, we are almost at the end of our latest project with the high AD utilizers. And I say latest project, but that was one of our first projects when we started with the value-based contracts. So we want to kind of summarize what has happened, our findings, how we are approaching. And I believe this can be a message for those patients who are listening to us, because we share these videos with them. And this can be useful for those who are working in the accounts and the charts with us. So if you want to kind of give the background on what we do and then how high ED is important, and small population of high ED can have a huge impact in the overall, and trying to change the behavior of the system, including patients, hospitals, doctors' offices. We do a lot together every day. You and I, we do case conferences. So I'll let you speak to those.
Okay, thank you, Kamal. Yes, so starting kind of at the beginning, we have, as Kamal mentioned, contracts with many insurance companies in Delaware. So we have our providers who treat patients who have all types of insurance: Medicare, Medicare Advantage, Medicaid, as well as commercial. And with regards to all those contracts, we send a file with all the patients that we see to DIN, which is the Delaware Health Information Network. And then on a daily basis, they're able to tell us which of our patients have been in the ER prior day, admitted or discharged from an acute care facility. So that's where it begins in care coordination. Our care coordinators reach out to those patients because they've had an event that required them to go to the ER and or be hospitalized. So we reach out to get them scheduled to follow up with the provider, the PCP, primary care provider, so that they can ensure if they need any medication changes, to see a specialist, etc. We track on an everyday basis. Now moving on to the nurse side, we track those patients who may have high utilization. And we look at those to see primarily what is the reason for their visit to the ED. Is it something that they need to be in the ED for? So certainly there are certain diagnoses. If a patient has, a seizure, if they have a sudden onset of blurred vision, other things like chest pain, broken bones, another like a traumatic fall. Those are all reasons they would want to go to the ER, because you don't know the extent of that injury or illness. Other times we see patients who maybe they don't know where they're supposed to go. They just know they're having other types of symptoms. So maybe they've had flu-like symptoms for several days, a headache, maybe I think I have a upper respiratory infection. So they're going to the ER for those types of purposes. And if you've been in the ER recently, you probably see that they're very full. I've been there recently myself with a family member, and you see patients on stretchers in hallways and in wheelchairs, sitting up and down the halls. It's because they don't have the capacity to handle all of the day-to-day things, right? They're really there to handle those more critical events. So I think one of the things that we look at is, again, education to that patient, because as Kamal mentioned, we look at utilization and cost. So the cost of going to your primary care provider or even an urgent care for things like headache or severe migraines, upper respiratory issues, those types of things. It's about 1/5 the cost, right, of going to the ED for those same types of illnesses or injuries. So that's one thing to keep in mind, because if you pay for your insurance, right, and you wonder why your expense goes up on an annual basis, it's because it's based on the claims dollars spent the year before. So that's one of the things we try to take a look at and help our patients to get in with the specialists that they need, the PCP more regularly, to help keep that cost down. And usually you will find that you can get in to see a provider the same day. In many cases, they do save appointments called same day appointments for injuries or illnesses. If not, they would generally refer you to an urgent care. Again, they're walk-in clinics. They have extended hours. They're usually open 7 days a week. So they can get you in more timely to be seen. You're not sitting in an ER for 8, 10, 12 hours with someone coming in and out periodically, right, to help you through that. So I think that's one of the things that we spend a lot of time looking at. Those cases, as Kamal mentioned, we do present cases on a daily basis. Our nurses review those cases and present them. And so with regards to that, we do look at that. We send emails out that help educate the patients. Maybe they're not aware that they can call the provider and be seen that day. Maybe they're not aware they can go to urgent care. So a lot of it is the educational side of things, and then also getting them in with their primary care to hopefully prevent them from having to go back to the ER again, getting them in with a specialist when needed to help treat some of those symptoms that they may have gone to the ER for.
So I'm sharing on the third screen there with when they should be receiving treatment in the ER versus not. So, from the beginning of our ACO structure, one of the things that we said, we are going to change the behavior of the system. And we have done a lot so far, and then we do see the impact, which is not a fast, quick impact. It takes several years to get to where we are. But this is where we can control certain things, like in the provider offices, we can, maybe in the hospital settings, the hospitals can. But when it's about the patients, depending on what emergency they have, that's kind of like, that's the key for patients to know when to go. So if we can kind of talk about our efforts on how we are trying to communicate this with the patients, educating the patient with what they have available to them. Now we also need to kind of discuss the Medicaid part of this problem. I say problem because when the patient has no accountability in terms of the cost, certain spendings, it can be a little more liberal than what you would expect. So can we talk about those a little bit?
Sure. So I guess starting with where do I need care? We started this many years ago. In fact, I think Highmark was one of the ones that came to us first, right? And we put posters up kind of educating and showing the patient, when do I go here? So as Kamal mentioned, we have things that are listed. And of course, it's not going to be all encompassing, but we want patients as part of that education. So we put posters up in the waiting room in our offices. So while they're waiting for a provider to come in and see them, we send out, as I mentioned earlier, emails to them to make them aware. We've also tried to partner with the ERs also as part of that education process to let them know day-to-day things. I have allergies, like I said, the headache. We see all of these. I have, and again, not the severe shortness of breath, not chest pain. That's when you want to go to the ER and you want to be seen timely for those types of things. But if you have, like a small rash that comes on, a sore throat, those kinds of things, that's where we try to tell the patient, call your primary care first. If it's a weekend, again, those urgent cares are open, and that's why they opened. Because as we know, there is a primary care shortage. So there are not always enough appointments to be seen in the primary care office. So making those available. And there are many probably right near you. There are a lot of urgent care walk-in clinics, they're often called. And again, they're primary care providers who treat there. And they're able to see you very timely. Usually there's only, minimal wait of maybe a couple of hours versus 8 to 10 hours in the ER. And again, saving that ER for those, trauma and more serious events. So talking a little bit about the Medicaid population, I do think that because, as you pointed out, there is no impact, right? There's no reason for accountability. For those of us who may have insurance, for our employers, the commercial insurance, we see, right, when we go to the ER, I know personally mine's $150. It makes you kind of stop and think, is this something I can see my PCP for, or urgent care where I'm paying my regular copay, versus $150. If I have severe chest pain, yes, I'm going to go to the ER and not think about that. But if I have a headache, or if I think maybe I have the flu or things of that nature, I'm going to call my PCP and I'm going to go see them or urgent care. To your point with Medicaid, and we've heard from some of the patients, well, I don't pay for it, so I just go there. And there is no accountability, but one thing to remember is free is not free, right? Somebody's paying for it. And so that means our tax dollars, those are all the things that are paying, right, for those. So we want to make sure that the patient is educated.
Like not just for the other, like for Medicaid, it's not just for the tax dollars, taxpayers, but also that benefit may not be there anymore. So
Sure.
like they may not be paying anything this year,
Right.
but then next year when we are running out of funds, those things, right? Because it doesn't mean that you'll never pay for that. The payment can come in the form of dollars or form of availability, eligibility, qualification. So the patient can actually lose some of those benefits easily. So that's we definitely want to actually emphasize that in a way that, so what's available today, like when you look at the Medicaid program, so you credit to our state administration, our governor, lieutenant governor, the way that our Medicaid program is in this state is very much different than any other state. So we have one of the best plans and program in place for Medicaid. And if we can keep up with that,
right,
at some point things are going to be changing. How it's going to change? People are going to only want to pay so much taxes. So then, if you max that part out, then now you have to go and see if who's going to be eligible with the poverty
I was going
level.
to say, so it's going to reduce that. So if you only have so many funds available, right? How do we use those? And so either A, people are going to get less, so you can give more people something, or you're going to have less less people who are eligible for that. Because again, there's always going to be a ceiling on the amount of money.
Right.
It's not just to infinity, right? We know that there's always going to be a max out there. So yes, I think there's a lot of different points. And if we can get them the treatment they need at a lower cost, then I think that's a win-win for everybody. It's more timely treatment. It's helping them in the overall care for them.
Right now, 33% of the population that we have with the high ED patients who had more than 7 hospitalization in the last 12 months in the form of ED visits or admissions. 33% of those patients are going to the hospital for PCP-related issues. So those can be handled in the PCP offices, and you and I, we do the case conferences, and you are in charge of all the nurses under United Medical ACO and your care coordinators with the hospital follow-ups and other things that we do. When it's a Medicare patient, our approach is different because, especially, you and I, how many times we talk about this, if the patient is 86, 87, 89 years old, they need to go to the hospital when something happens. But if it's a younger patient without those chronic problems or age-related problems, those are the ones we have a different approach. But then our approach is kind of like limited with the ones with commercial insurance versus ones with Medicaid, which almost can be half-half in
Being
today's
able to
market.
reach the patient, right? That's a large part of it. So I had mentioned earlier, right, that it starts with the care coordinators reaching out to schedule the patient. And, we reach out 3 times, so twice by phone typically, and then we send a letter. Just letting them know and starting that process so they can always call back in and schedule that appointment. So that part is critical. And then, yes, most of the time when we look at that and we see it's a Medicare patient, they do have multiple chronic conditions. And in many cases, not only are they in the ED, but they may be admitted, right? Because they do have a lot more going on that requires more intensive treatment on an inpatient basis. So I think that's one of the other things that we look at as far as the nursing component.
So the other problem, I'm going to actually share my screen. Normally, I don't like sharing screen, so then we would be visible, but just so that you can kind of also see one of the other things that we have from our findings is those who are going to the ED, how many of them have addiction problems, right? So this is a small group that we have. I say small group, but 39 patients that we have here have either alcohol or drug-related addictions. And then if you look at the average, like 39, it's almost like each of them have 10 ED visits, almost averaging. So when you look at hospitalization 400, so that's about 10. So this is one of the costliest groups that we actually are very limited with what we can do. Now I'm going to stop sharing so then we can kind of bring the hospitals in the picture and then and also insurance companies in the picture to see what is expected from us is not actually reasonable. So that's why we need to have a different approach.
And yes, and so we try to collaborate with our insurance companies. So we have ways that we collaborate with them in monthly meetings. We also collaborate with them by sending referrals over so that they too can try to reach out to the patient and engage them, right? That's the biggest key, is engaging them in that care. As far as the hospital, we've tried to work with them on, I think the direction you were going from all with, work with them on real-time notifications so that we could, while the patient's right there, that would be an ideal time for us to reach that patient and get them scheduled to go in to see their PCP. Unfortunately, in many cases, we've been unsuccessful in being able to do that. But that would eliminate us, in many cases, not being able to get a hold of the patient and also trying to get them engaged in that day-to-day care that they need with the PCP and then on to a specialist if needed.
So now, I want to make sure, especially if our providers are watching, so I don't want them to think that we just started this was our first focus for the ACO in 2015-16 time frame. So we just wanted to bring a new approach by using the data that we have, because these numbers that you see here are not necessarily readily available from the insurance. I'm going to share one other screen so that way all of them would be kind of discussed with the data, supported with the data. So this is between the hospital and PCP related. If the patient really needs to be in the hospital, we mark them as hospital versus if it's a PCP related. So that's 257 total patients, 2,100 total hospitalization, and this is 1/3 of the patients are actually almost 1/3 of the patients are going to the hospital with the ED. So when what we are trying to accomplish is to make sure that insurance companies are understanding, and instead of making us fully accountable for those where we don't have full access and they have better access, most hospitals, when they don't have, when they have a patient right in front of them and we don't in some cases, because some of these patients, they are also not the patients that are seen by us. We still have the data,
Exactly.
but they are being assigned to us. So I'm hoping that we can actually use this. So our goal is to utilize these on a monthly basis in our ACO insurance meetings, so then we can actually put the pressure back on the insurance companies. So I know Anthony is going to join me after this. So anything that you want to
I think we pretty much covered everything, but talking about the insurance companies, so we do need them because that's who the patient has, right? They're paying the claims. So we need to have that collaboration and that, co-ownership of this patient,
Right.
right? Because we want to treat the patients, and they want the patients to be treated. So we have to find a way to work together to put the accountability also on the patient, right? If they're given, like the Medicaid insurance, to maybe have some requirements there, with them maybe having a PCP visit within a certain number of days of becoming eligible. So, again, working with that, but I appreciate you giving me the opportunity to talk about
we
this.
work together every day. So of course I have to give you the opportunity. So this is important for us. And I believe that like one of the reasons that I want to emphasize what's happening with the hurricane, this has impact overall in healthcare. The supply chain is going to be impacted. And we already, from our surgery center, we already have some alerts coming to us where there will be some shortage because of the hurricane, and things are coming from that channel, from that route, and certain things won't be available. So this is true for the hospitals. So if we are not reasonably, responsibly using our sources, our supplies, then we are going to be in trouble for providing that care for the people who are really in need of those. So I'm hoping that we can make some impact on those individuals. So Donna, thank you for joining me, and I know in a couple of minutes Anthony is going to switch with you. While he's doing that, in the next couple of weeks, we are going to have some new topics. Now, next Friday, actually, Sarah McBride is going to be with us. She's already confirmed. She is going to be our next congresswoman for Delaware. And most of you may or may not know, but Delaware has only one congresswoman or congressman. So that's based on the population. And she's going to be with us. That's going to be her 5th time. I went back and watched actually the first episode that I had with her was very emotional, and I know that was one of Anthony's favorite one. So we are going to actually see how she's doing, and if she needs anything from our side to support her, and make sure that everyone is aware of where she is with certain projects that she has. Now, one of the other topics that we are going to discuss in the future is the social media and the double-edged sword in political propaganda of the social media. And Sean is off today. He and we are going to prep for this. I see the utilization of social media channels and how it's impacting the society. And I always say, one of the really important issue for people to understand is certain things used to be done in different ways. They're always going to change and find a new form. Like the main goal is never going to change. Like I remember watching one of the seminars long time ago. The reason these mass like soccer and big sports games are kind of the way it is, so that they can occupy, keep the people busy. So when your team is winning or losing, that becomes the center of your life, center of attention for your life, and then you don't really pay attention to a lot of other things. This was in 1930 and 1940. Now, you can actually still see some people can actually harm others if their team is losing. So that social media at that time was the big sports teams. So today it's Facebook, it's Twitter, it's X, it's Instagram, it's Discord, all these Telegram, all these different channels. Because what I see is again and again there are fake or bot accounts where they repeat, copy paste the news, and then all of a sudden you see the same thing from 200 different accounts, and then it does show on your feeds. Then you can help and pay attention to it after you see it like several, you ignore it, but then the 10th time you kind of see what it is. But then it's how they're brainwashing people, and then they're trying to kind of increase the anxiety of the societies where we see several different ways, like the Soros Foundation. But what they have done in the 2013-14 timeframe, they did it in the North Africa, they did it in the Middle East, they did it in Turkey. So they use different channels. I just want to make sure that we can actually kind of approach that issue and then see what type of utilization to screen. Like, for example, I believe personally is that everyone who owns a social media should be verified with their social security number, or if they're in Turkey, with their kimlik numarası, so they call. So, like if Anthony Anugu, who's in my office, who's in the studio right now, he can turn his video on so then I can include him in the discussion before we start his topic. Like if he has an account with Facebook, it has to be verified with his social security number. So then we know that person who controls that account is the person who actually controls the same person who is actually who owns the account. So then we have legal responsibility every time we put something out there, and then we attack someone without being able to substantiate our points. Like, for example, if you are on the street and then you try to attack someone, you know that physically that person can beat you up, right? So, but when you're on the behind the keyboard, you can be the bravest person ever because they don't know who you are. So if this is a business, they should be verified with their tax ID numbers. I personally should not own, 7 different X accounts, Twitter accounts. I have, so I shouldn't have to own that. It shouldn't be allowed. Now I use it properly to promote our own stuff. But if I were to own 2,000 accounts, then I would be creating some brainwashing activities on certain populations. So that's kind of like, that's my approach at least. But we are going to discuss this. Anthony has 2 kids. They're young teenagers. So I'm sure he's probably struggling with some of these issues the way that I haven't discussed this with Anthony. I don't want to put you on the spot. I'm just pointing out this is an important issue for everyone. So it's one of the, perhaps it's one of the worst time to own, not own kids, right? To have kids, because the control that you have over the kids is so limited. What they are able to access through the internet is extremely concerning. So, Anthony, how are you doing?
Yeah, I'm good. Thanks, Kamal. Thanks for having me.
Of course. So we want to discuss the state policies, upcoming bills that we have that's related to healthcare, and you prep some of those, and we are with you now.
Yeah, it was the General Assembly sessions that just ended. was a healthcare for healthcare policy available. Of course, we all know it's an election year, but then it's ended with a bang, so to speak, for a number of reasons, which we'll get into. First, generally speaking, we have health insurance, the health insurance marketplace. We have our plans for 2025 now approved. In the last 2 years, consistently had new entries into the market, but this time around, that's not going to be the case. The 4 plans that in the market remain, and by that I'm referring to the marketplace plans. 45 new benefit plans were approved, and all the insurance companies, I think, requested rates increases, but most of them were not granted this at the level that they wanted. I think that the state has the advantage currently, the advantage of an insurance commissioner who's very customer oriented in terms of how he visualizes his role and his position and what is done over the years. We also have a situation where the CMS waiver that the state applied for and received and has since renewed allows it to be able to provide a reinsurance in the marketplace, a reinsurance scheme in the marketplace, which is helped to stabilize prices. So we're far ways away from where we were at the beginning of the implementation of the marketplace plans, the so-called Obamacare. That's the first overview. I did say that the General Assembly session ended with a bang, and that being a veto by Governor Carney.
This is 140, right?
Yeah, House Bill 140. And that's the physician-assisted suicide bill, passed very narrowly by both the House and the Senate. I think maybe one vote difference in one of the chambers in passing it, if not the two.
Well, that's what it makes the difference, right? One is one.
Yes, so. Yeah. It always can be very decisive. In the country as a whole, there are about, I think, 11 states with assisted suicide.
So what's your personal take on that?
Well, first, I'm a Catholic, and the Catholic Church...
That makes things more difficult.
The Catholic Church was heavily against the bill, and beyond the religious affiliation side of it, I am actually in agreement with Governor Carney on it. I think that there are arguments on both sides, and there is no really firmly established consensus around this. The American Medical Association, for instance, is of the opinion that this is not something that should be saddled on the physicians. Part of that, it doesn't necessarily agree with their own role in medical care. So I'm on the side of.
So I'm gonna actually corner you a little bit. So because you said because of the religious reasons, and if you don't make it personal, it's not dramatic. So then we can really just get the real opinion out of the people. That we are in healthcare, and then you are part of our clinical integration, and then contracting with terms that we have. Like administratives is one of the things that we have, which actually supposed to be helping people to make decisions, but also the other side of it is for those unnecessary expenses at the end of their lives.
Yeah.
And when I say this, I want you to, you already know that I have parents who are, my dad is 83 years old. So I have an aunt who is going through a lot of issues with her Alzheimer. So we have, one-on-one, we see these problems and issues very closely and can see what it does to the individual who's going through those issues. But if I were in the situation where I'm not able to make a decision at that time, and if I know that I'm going to be in, the tube fed for 60 days, I don't want that. Now, I'm a person who didn't want to put my body down, this, and I was praying for the whole time that he would be able to just die on his own because he was 13 and a half, had some issues and a lot of difficulties. But it was at a point where he was in pain. So in pain in a way that he was asking for help. And that was the last sort of for me, but we had to do it. I had to do it. So if I was in the same situation, I'm in the hospital bed for 60 days on the tube and no conscious, I want to make that decision before that happens. Now, in that situation, would you still want to just keep it the same?
Yeah, my counter to that will be that healthcare already provides for these eventualities through the advanced care plan,
Right.
and then through palliative care, right? But physician-assisted suicide, in my view, goes a step further than what it does and essentially puts the decision on the physician, right, to implement the end of patient's life. Right. But the examples you gave are addressed already by the advanced care and the advanced care plan. And it's I would argue, is the core reason why advanced care plan is encouraged. And individuals, so I remember when I went, when I was in MBA school for healthcare and administration, one of the things that we did go through as part of ending our degree was actually establishing an advanced care plan for yourself, right? And learning how that process plays itself out. And I think that my response to that is that there's a medical and a substantial basis for establishing advanced care plans, and that's what addresses that. But the assisted suicide, I view, is a step further than that, and that's why I agree with American Medical Association with this, and in full support of Dr. Khan's veto. It should be pointed out that the General Assembly could have attempted to override the veto, but they did not, because they simply did not have the votes to do that.
And also, I guess it's a little bit different, right? So when you are not able to make that decision and then stop the life support versus making that extra, take that extra step to put yourself down. In that case, maybe that's one of the difference, to be fair, for both of us. So we are not actually discussing the time of where we are unconscious and we know what we are going to do that time. Because when you are in that situation, you are pretty much once the term we call, like, if someone's unplugging you, then you are going to die on your own anyway. So that's not a suicide. So it's not the most fun topic, but it is what it is. And Bombeck was here, right, last year. And when he actually brought that up, I was like, not sure if I would be supporting that or not, but he did go through it then. And now the problem is Matt Meyer is actually supporting it. And by the way, Matt actually may or may not, but he may be on with us before the elections. we'll see what's coming from that. But he's supporting it. As soon as John Carney vetoed that, he actually posted to it, tweet saying that once he's the governor, he's going to be supporting that.
It still has to overcome the veto. It still has to pass both the chambers, and that's not going to be easy at all.
Mhm.
Even with all the amendments that were made, it's still heavy. Now there's, I guess, more foreign healthcare legislative outcome is the paid family leave signed into law, and as we speak, there are about 8 plans in the market, in the private insurance market. The way the paid family leave act is structured is that there is a public component of it, which the state essentially has set up, sort of like the so-called public option. Then there is the private marketplace where companies can buy into on their own, and these plans are already pre-qualified. At the same time, a company that chooses to have its own entirely separate plan already has something in place, can have that approved through the Labor Department. It was signed very recently, and you recall that Sarah McBride was here when she was initially proposing this. I would say that this is an exemplary case of successful legislative action by any legislator that I have seen in recent times. The manner in which she was able to, she had the initial ideas, but had the understanding and the flexibility to be open to new ideas, and especially the manner in which she built the coalition around us, right, to the point where the major employers in the state, including us, were rooting for her and were very supportive of the bill, all the way to its actually being law in the state of Delaware. It not only helps to stabilize the employment market itself by providing a crucial element of employee benefits, but it also does that in a manner that is market-based by creating that insurance marketplace for it. As I mentioned, its plans already approved, and there are 11 more filings, which is indicative of how, from a purely economic standpoint, this is actually a very viable. Not just that it's a very socially benefiting, but also economically viable. And I think the state of Delaware, should she win the election, that first class,
she will win the election. There's no if.
the state will have a first class representative. She's truly excellent.
Well, I mean, you can't really solve the problems with old tools, right? So like, there are new problems, new issues. Then you have to have a new approach. So that's kind of like where the main thing that I see with her is that you have to be able to come up with new solutions and then find new tools to fix the problems. And I think that's where she's going to make a big difference. And for Delaware, it's an interesting time where now we have Chris Coons. Chris Coons, I worked with him since 2010. In fact, I was one of his big supporters in 2010 when he was not, like, he wasn't expecting that position. Like, he's replaced Joe Biden's seat, and there were someone who was appointed by the governor at that time, Jack Markell, and then I can't remember his name, but he was Kaufman. I don't know how I remember that, but it is Kaufman. So one of his friends from all times. So then Chris actually now is a senior senator. So, and he's also one of those who has different approaches in politics and good understanding of issues that we deal day to day. And I believe he's going to be, perhaps maybe he's going to be in the cabinet when, well, after the election, we don't know. He may be, he's at that point now. Foreign relations, he's superior, and he may be actually the next Secretary of State. So if it does happen, so our team should go back and then take this and make it short so that we can say, we told you so. But this is a big possibility that can happen. Now, then we have Lisa Rochester. I was with her last Tuesday. And one thing that I will also emphasize, why it's important for healthcare organizations and healthcare providers to know and be close to these policies and new bills is because these individuals in the Senate and the House, they are lawmakers for us. So if, in the event that I attended last Tuesday, Christian Hospital was there with the full leadership. I never have seen them in that capacity in any of these events, but even the CEO was there, meaning that they know that they are not very happy about the HB 350, and now they want to actually probably make sure that they have Lisa's ear with those issues. So this is why we are also interested, and this is our job. It's part of our job. So, and I think I totally agree with you, with Sarah. And I think she's going to be an excellent addition to that team. Now, imagine if the oldest person there is now Chris Coons. So, that's going to be an interesting team. And we want to make sure that we can, work with them closely as we are already doing that. Now, what else do we have?
The other side of it, there's the Mental Health Parity and Addiction Equity Act. Now, this has to do with enforcement action by the Department of Insurance against Hyman. The Mental Health Parity Act goes all the way back to 2008. Was passed at the national level, led by two senators, Pete Dominici and Paul Wellstone, the senator from Minnesota back then. And so we have this act at the national level and also at the state levels. It seeks to have parity in reimbursement between medical services and then mental health services. And the law requires yearly review by the Department of Insurance to ensure that insurance companies are reimbursing at the same level for mental health services. The rationale for the act was always that you needed this in order you have to discourage those with mental health issues from seeking care or disincentivizing the providers themselves from providing such care. And Highmark was fined a little bit of a substantial amount of money they would find in that regard. David Blacksmith implemented several remedial actions to ensure that this does not go on. We go through the issue of mental behavioral health, substance abuse issues in our value-based contracts. And as you discussed in the prior segment, this is very significant, especially when you're dealing with members who are high ED utilizers, and you see that a significant segment of that population always and always fall in the category of the substance use disorder patients. So these all they are significant in the way they affect not just the reimbursement on the fee-for-service side, but also the value-based side of
No, I agree. So, Anthony, I think we should probably periodically put these updates with through this event, like maybe every 3 months or so, because I think that's a good exercise for us, as well as in some of them we may have our specific messages, so then we can also discuss those, and then when they are here as our guests, we can actually address those issues that are important for us. Now, Dr. Wynn is in our studio. She's going to join us for Bariatric Friday. So we thank Anthony and Donna joining us. And then we'll be back in a couple of minutes with our Bariatric Friday with Dr. Gail Wynn.
Thanks. Thanks for
Thank you.